Dr. Malik Hassan Mahmood. We will discuss hypolipidemic drugs today. Firstly, let's take a look at a patient's case. Mr. Aslam is a 48-year-old executive for a large multinational company who works long hours and frequently has to travel abroad. He has a family history of coronary heart disease, and 9 months ago he attended a coronary screening clinic for a health check. At the clinic he was found to have a normal blood pressure, but a blood screen revealed a total cholesterol of 5.7 millimole per liter and triglycerides of 11.8 millimole per liter. When he revisited the clinic 4 weeks later after trying to follow dietary advice, a fasting blood sample revealed a total cholesterol of 5 millimole per liter and triglycerides of 2.7 millimole per liter. Liver function tests were normal. He is a non-smoker and claims never to drink more than 10 units of alcohol per week. After repeated requests to revisit the clinic, he eventually turned up, stating he had been away from home for 6 months on a series of business trips. He was trying to keep to a low-fat diet, and his blood profile revealed total cholesterol 5.7 millimole liter, triglycerides 4.3 millimole per liter, HDL count 0.8 millimole per liter and LDL count 3 millimole per liter. Our questions are: is Mr. Aslam at high risk of coronary heart disease? Is Mr. Aslam a candidate for lipid-lowering therapy? Should Mr. Aslam's children be screened for dyslipidemia? Coronary artery calcification versus coronary artery disease. How many classes of drugs are used to treat hyperlipidemia? Write in detail. At least 4. Detail the mechanism of actions, pharmacokinetics, adverse drug effects and drug-drug interactions of anti-hyperlipidemic drugs. Today we are going to discuss brief about hyperlipidemia, classification of anti-hyperlipidemic, pharmacodynamics, pharmacokinetics, adverse drug reactions, drug-drug interactions, total cholesterol, LDL, HDL, triglycerides. Our categories is normal hyperlipidemia, hypertriglyceridemia. HDL. Its risk factors are NMR, age, sex, history, genetic predisposition, MRF, smoking, atherogenic diet, obesity, diabetes, metabolic disorder, physical activity. Emerging risk factors, CRP, fibrinogen, coronary artery calcification, homocysteine, lipoproteins, small dense LDL. Lipid-lowering drugs are statins, fibrates, bile acid binding agents, cholesterol absorption inhibitors, nicotinic acid and derivatives. Agents such as soluble fiber and fish oils have also been used to reduce lipid levels. A number of new agents are also under investigation for their novel effect on different parts of the cholesterol biosynthesis pathway. Statins, the statins, which selectively inhibit 3-hydroxy-3-methylglutaryl-CoA reductase HMG-CoA reductase, was a significant advance in the treatment of dyslipidemia. Their primary site of action is the inhibition of HMG-CoA reductase in the liver and the subsequent inhibition of the formation of mevalonic acid, the rate-limiting step in the biosynthesis of cholesterol. This results in a reduction in intracellular levels of cholesterol, an increase in expression of hepatic LDL receptor, and enhanced receptor-mediated catabolism and clearance of LDL cholesterol from serum. Production of VLDL cholesterol, the precursor of LDL cholesterol, is also reduced. The overall effect is a reduction in total cholesterol, LDL cholesterol, VLDL cholesterol, and triglycerides with an increase in HDL cholesterol. The reduction in LDL cholesterol occurs in a dose-dependent manner, with a lesser and dose-independent effect on VLDL cholesterol, and TGS. Simvastatin was the first member of the group to be marketed in the UK, followed by Pravastatin, Fluvastatin, Atorvastatin, Simvastatin and Rosuvastatin. Simvastatin was withdrawn from the market in 2001 due to an observed increased risk of fatal rhabdomyolysis, whilst Rosuvastatin, the newest member of the group, was launched in March 2003. The efficacy of statins has been demonstrated in a number of landmark randomized placebo-controlled trials. A greater absolute benefit was seen in those trials that involved established CVD, that is, secondary prevention studies, compared to those that involved individuals without established CVD, that is, primary prevention studies. Statins are currently the lipid-lowering agents of choice in both primary and secondary prevention of CVD. Is there any need to use statins or not? There is a need to identify patients who need treatment, ensure they receive an appropriate, effective dose of a statin and adhere to treatment. Despite overwhelming evidence of benefit, effectiveness is frequently compromised by poor adherence, with up to 50% of patients discontinuing treatment within 12 months and 75% within 3 years. Patient factors that influence this include perception of risk, side effects of medication, expected treatment duration, and socio-demographic factors. Rosuvastatin, the most potent of the statins, with evidence of impact on morbidity and mortality. It is normally reserved for those individuals that have had an inadequate response to their first-line statin. There remain concerns about its safety profile and rhabdomyolysis. In particular, when used at the higher dose of 40 mg per day, it is recommended that this dose should only be used in individuals with severe FH and at high cardiovascular risk under specialist supervision. In patients of Asian origin, Japanese, Chinese, Filipino, Vietnamese, Korean and Indian, the maximum dose should not exceed 20 mg per day because of their increased predisposition to myopathy and rhabdomyolysis. Newer agents are acyl coenzyme A, cholesterol, acyl transferase, ACAT, inhibitors are ACAT esterifies excess intracellular cholesterol. Inhibition of ACAT prevents transport of cholesterol into the arterial wall and thereby prevents atheroma developing. Lowers VLDL cholesterol and triglycerides. Bile acid sequestrants related to first-generation resins, but improved patient tolerance. Sequester bile acids and prevent reabsorption. Reduce LDL cholesterol while HDL cholesterol and triglycerides increase or remain unchanged. Cholesterol ester transfer protein inhibitors is responsible for the transfer of cholesterol ester from HDL cholesterol to the atherogenic LDL cholesterol and VLDL cholesterol. Lipoprotein lipase activity enhancers is responsible for VLDL-C catabolism with subsequent loss of triglycerides and increase in HDL-C. Protects against atherosclerosis. Microsomal triglyceride transfer protein inhibitors inhibit absorption of lipid and reduce hepatic secretion of lipoproteins, thereby reducing atherosclerotic plaque formation. Peroxisome proliferator activated receptor activators. Peroxisome proliferator activated receptor alpha and gamma regulate the expression of genes involved in lipid metabolism and inhibit atherosclerotic plaque rupture. They reduce entry of cholesterol into cells, lower LDL cholesterol and triglycerides, and increase HDL cholesterol. Squalene synthase inhibitors inhibit squalene synthase, upregulate LDL receptor activity and enhance removal of LDL cholesterol. Adverse effects are the commonest include gastrointestinal symptoms, altered liver function tests and muscle aches. Less common are elevation of liver transaminase levels in excess of 3 times the upper limit of normal, hepatitis, rash, headache, insomnia, nightmares, vivid dreams, and difficulty in concentrating. Myopathy, unexplained muscle soreness or weakness, leading to myoglobulinuria secondary to rhabdomyolysis, is also a rare but serious potential adverse effect of all the statins can be at any dose. The risk of myopathy is increased when there are underlying muscle disorders, a family history of muscle disorders, renal impairment, untreated hypothyroidism, alcohol abuse, or the recipient is aged over 65 years or female, where statins are co-prescribed with other lipid-lowering drugs, for example, fibrates, nicotinic acid. When there is a past history of myopathy with another lipid-lowering drug or statin, where there is co-prescription of simvastatin or atorvastatin with drugs that inhibit CYP3A4, the risk of myopathy is increased. The statins are a heterogeneous group metabolized by different CYP450 isoenzymes. Simvastatin, atorvastatin, and levastatin are metabolized by CYP3A4. Fluvastatin is metabolized by CYP2C9, and pravastatin and rosuvastatin are eliminated by other metabolic routes and less subject to interactions with CYP450 isoenzymes than other members of the family. The risk of myopathy is increased. Caution is still required as a 5 to 23-fold increase in pravastatin bioavailability has been reported with cyclosporin. Simvastatin and atorvastatin do not alter the activity of CYP3A4 themselves, but their serum levels are increased by known inhibitors of CYP3A4. Interaction of statin with CYP450 inducers and inhibitors is given here. Here are CYP450 inducers and inhibitors. Avoid prescribing statins with, avoid simvastatin with. Potent inhibitors of CYP3A4. Do not exceed following doses, avoid grapefruit juices when taking these medicines. Atorvastatin to be used cautiously with CYP3A4 inhibitors. Now we will discuss fibrates, bezafibrate, ciprofibrate, fenofibrate and gemfibrozil. They are thought to act by binding to peroxisome proliferator activated receptor alpha on hepatocytes. This then leads to changes in the expression of genes involved in lipoprotein metabolism. Consequently, fibrates reduce triglyceride and, to a lesser extent, LDL cholesterol levels. While increasing HDL cholesterol, fibrates take 2 to 5 days to have a measurable effect on VLDL cholesterol, with their optimum effect present after 4 weeks. In addition to their effects on serum lipids and lipoproteins, the fibrates may also have a beneficial effect on the fibrinolytic and clotting mechanisms. The fibrates also produce an improvement in glucose tolerance, although bezafibrate probably has the most marked effect in the patient with elevated triglycerides and gout. Only fenofibrate has been reported to have a sustained uricosuric effect on chronic administration. Fenofibrate and ciprofibrate being the most potent members of the group. Mechanism of action of fenofibrates is given here. Role of fenofibrate in metabolizing lipoprotein, fatty acid, and cholesterol. Despite the effect of fibrates to reduce triglycerides and increase HDL-C, statins are first-line lipid-lowering agent in most guidelines because of a lack of clear evidence that fibrates prevent cardiovascular disease and diabetes. Overall, fibrates should not be used first-line to reduce lipid levels in either primary or secondary prevention. Fibrates can be used first-line in patients with isolated severe hypertriglyceridemia. In individuals with mixed hyperlipidemia, fibrates may be considered when a statin or other agent is contraindicated or not tolerated. Adverse effects are, symptoms such as nausea, diarrhea and abdominal pain are common but transient, and often resolve after a few days of treatment. Myositis is associated with muscle pain, unusual tiredness or weakness. The mechanism is unclear, but it is thought fibrates may have a direct toxic action on muscle cells in susceptible individuals. Fibrates are known to significantly increase the effect of anticoagulants, while concurrent use with a statin is associated with an increased risk of myositis and, rarely, rhabdomyolysis. Concurrent use of simvastatin and gemfibrozil was noted to cause rhabdomyolysis, and this contributed to the withdrawal of simvastatin from clinical use in 2001. Bile acid binding agents are cholestyramine, cholestyramine and cholestyramine. Both cholestyramine and cholestyramine were formerly considered first-line agents in the management of patients with FH but now have limited use. Cholestyramine is the most recent of the bile acid binding agents to receive marketing authorization in 2004, and consequently has never had a first-line indication. Each of the bile acid-binding agents reduces total cholesterol and increase triglyceride levels following oral administration. Neither cholestyramine, cholestyramine, nor cholecylamine are absorbed from the gut. They bind bile acids in the intestine, prevent reabsorption and produce an insoluble complex that is excreted in the feces. The depletion of bile acids results in an increase in hepatic synthesis of bile acids from cholesterol. The depletion of hepatic cholesterol upregulates the hepatic enzyme 7-alpha-hydroxylase, which increases the conversion of cholesterol to bile acids. This increases LDL receptor activity in the liver and removes LDL cholesterol from the blood. Hepatic VLDL-C synthesis also increases, and it is this which accounts for the raised serum triglycerides. Cholesterol absorption inhibitors are ezetimibe is a 2-azetidinone derivative that interacts with a putative cholesterol transporter in the intestinal brush border membrane and thereby blocks cholesterol reabsorption from the gastrointestinal tract. It can reduce LDL cholesterol by 15 to 20% when added to diet. Ezetimibe also brings about a small increase in HDL cholesterol and a reduction in triglycerides. Ezetimibe should be prescribed either with a statin, a fibrate, or a nicotinic acid derivative, and rarely by itself, and then only in statin-intolerant individuals. Ezetimibe should be prescribed either with a statin, a fibrate, or a nicotinic acid derivative, and only in statin-intolerant individuals. Castlein et al. And Rossab have demonstrated an additional reduction in cardiovascular morbidity or mortality that could be attributed to ezetimibe. Although apparently well tolerated, no long-term trials. Nicotinic acid derivatives are: nicotinic acid lowers serum LDL cholesterol, total cholesterol, VLDL cholesterol, apolipoprotein B, triglycerides, and Lp(a), and increases levels of HDL cholesterol, particularly the beneficial HDL. It clearly has a range of beneficial effects on the lipid profile and is licensed for use in combination with a statin, or by itself if the patient is statin intolerant or a statin is inappropriate. The commonest side effect of nicotinic acid is flushing, which is most prominent in the head, neck, and occurs in over 90% of patients. It is cited as the major reason for discontinuation of treatment in 25 to 40% of patients. A number of strategies have been devised to overcome this, including co-administration of a cyclooxygenase inhibitor such as aspirin. Alternatives are: other strategies include regular consistent dosing, the use of extended-release formulations, patient education, dosing with meals or at bedtime, and the avoidance of alcohol, hot beverages, spicy foods, and hot baths or showers close to or after dosing. Less common side effects of nicotinic acid include postural hypotension, diarrhea, exacerbation of peptic ulcers, hepatic dysfunction, gout, and increased blood glucose levels. Acipimox is structurally related to nicotinic acid, has similar beneficial effects on the lipid profile and a better side effect profile, but appears to be less potent. An extended-release preparation of nicotinic acid has also been marketed to reduce the incidence of side effects, but up to 30% of users still report problems. The most recent nicotinic acid-based product to be marketed is a fixed-dose combination of nicotinic acid with liraprant. It is licensed for use in combination with a statin or as monotherapy when a statin is inappropriate or not tolerated. Liraprant is a potent, selective antagonist of the prostaglandin D2 receptor subtype 1, DP1. Given that prostaglandin D2 mediates the flushing associated with nicotinic acid, the rationale for the combination is sound. But there are currently no long-term trials of efficacy and tolerability. Lomtapid, microsomal triglyceride transferase protein inhibitors, MTP, is involved in the production of VLDL. After production in the liver, VLDL is released into the plasma. The enzyme lipoprotein lipase catalyzes the breakdown of triglycerides from the VLDL into free fatty acids. Hence, VLDL is transformed into LDL. By inhibiting MTP, Lomtapid reduces the production and release of VLDL. And LDL levels in plasma. A side effect of Lomtapid is the accumulation of triglycerides in the liver, which is probably due to the inhibition of VLDL-mediated release of triglycerides from the liver. Here is the mechanism of action of Lomtapid microsomal triglyceride transferase protein inhibitors. Role of lipid-lowering agents in metabolic syndrome is illustrated here. Detailed mechanism of action of lipid-lowering drugs is given here. Now this chart is representing typical recommendation for use of lipid-lowering agents. First-line drugs, second-line treatment and other treatment options are given. Let's discuss a patient's case for understanding. Mr. Asim is a 68-year-old man with stable angina. He is currently receiving Simvastatin 40 mg daily with well-controlled lipid levels. Total cholesterol 3.8 mmol per liter, LDL cholesterol 1.8 mmol per liter, HDL cholesterol 0.9 mmol per liter, triglycerides 1.3 mmol per liter. He has been on Simvastatin for the past 7 years, and has complained previously about muscle aches, but on this visit he states that his muscle pain has become more troublesome, to the extent that he wishes to come off the statin. He asks if there is nothing else he can take to control his cholesterol. What action would you take immediately? What options are available for Mr. Asim? What would you recommend to Mr. Asim? Thank you.